In today's talk about vasectomy reversals, we'll be focusing on when we need to perform a specialized epididymal reconstruction. We refer to this as VE. My name is Dr. Ryan Flanagan, and I'm a urologist trained in microsurgery and an expert in male reproduction and sexual medicine. So after you've had a vasectomy, the tube that carries and transports the sperm is typically blocked, or there's a gap in this tube. So a reversal of the vasectomy is putting the tubes back together so that the sperm can then get transported back into the semen afterwards. So during a conventional vasectomy reversal, it's as simple as putting the two ends of the tube back together using very delicate sutures under an operating microscope. This allows us to look at the tubes with a large degree of magnification, approximately 20 to 25 times, and allows us to precisely place the stitches to keep the open side of the tube on the inside open so the sperm can transport through, and the strong part of the tube, the muscularis, to firmly reconnect back. However, over time, the testicle continues to make sperm and a little bit of fluid since your vasectomy. Now, over time, this can lead to increased pressure in the structure that's directly adjacent to the testicle called your epididymis. The purpose of the epididymis is basically to store all of the sperm that's produced in the testicle, and this is a site for the sperm to be able to mature. Now, these tubes are very, very delicate, and over time with the increased pressure, one of these tubes can actually rupture, and if it ruptures, they'll typically scar down and create what's called a secondary blockage. If this happens, a traditional vasectomy reversal won't work. Unfortunately, we can't determine this exactly just by physical exam and a clinical history alone. The only way we can determine this is at the time of the surgery. So to figure this out, what we do at the time of the surgery, we make an incision through the tube just below the site of the vasectomy. We look at the fluid under a separate microscope and see if there's any sperm parts, if the sperm are moving or if they're still. This information then tells us, is the tube patent and is it open, or is there likely a secondary blockage? If there's a secondary blockage and we don't see any sperm or sperm parts in the fluid, or the fluid is thick and pasty, that's our indication that, in fact, we have to do a more specialized reconstruction, the VE, where we connect to one of those tiny epididymal tubules and move upstream of the blockage. In performing a specialized reconstruction called a vasoepididymostomy, or VE, which we commonly refer to it as, what we do here is we go upstream from the blockage. So we sample each of the little tubes from the end all the way back towards the testicle. Once we see that we can find sperm or sperm parts and we're confident that we're above the blockage, then using a highly powered operating microscope with 20 to 25 times magnification, we zoom in on one of these small tubes that we select, and we place these tiny sutures into it. They're typically smaller than the size of the hair on your head. So they're very, very delicate, but it allows us to make a very clean reconstruction here. We then make a small little opening in one of these epididymal tubes, and we stitch it into what's called the vas deferens, the tube that carries the sperm, which your vasectomy was done on. This reconnection will reestablish the sperm from the testicle going through those epididymal tubules into the tube that carries the sperm out to your semen. If we look at the literature rates, there's a huge variability in success. It really depends on the training, the experience, and the technique of the surgeon, and also obviously some surgical and patient factors as well. But as you can see in the images here, it's another example of how we bring the tubes together. The most common technique that we use is called the live technique. This stands for longitudinal intussuscepted vasoepididymostomy. So basically, it just means that we're taking the side of one of the small epididymal tubes and we're plugging it into the end of the vas deferens. And this has been shown to consistently have among the highest success rates in the literature. The image on the right is actually from a textbook from my mentor, Dr. Mark Goldstein, performing one of these vasoepididymostomies. So following the procedure, I often get asked in the clinic, when can we start trying? Well, if we look at the literature, the time it takes for sperm to come back into the semen after is somewhere between 3 and 6.5 months. I typically recommend holding off from ejaculating for approximately 4 weeks. The reason is it's a very delicate reconstruction and we want the tissue to heal very well. The tubes that transport the sperm are actually really strong. The vas deferens has the largest muscle mass per size of the lumen out of any tube in your body. So with an ejaculation, that can contract quite significantly. So by 4 weeks, we have about 70% strength in tissue healing. So after that, men are free to ejaculate. And again, somewhere between 3 and 6.5 months is when we typically expect to see sperm to return into the ejaculate after one of these procedures. So in summary, vasectomy reversal may require a specialized epididymal reconstruction, VE, if there's a secondary blockage. We identify this at the time of the operation. So when you're choosing your surgeon, ensuring that the surgeon has the skill set to either perform a conventional vasectomy reversal or one of the vasoepididymostomies is really important. These are certainly technically demanding and the results are quite variable across the literature. There are multiple VE techniques out there in the literature, but the live technique is used most commonly amongst male reproductive microsurgeons, and that's a technique that I prefer to use as well. Thanks for watching this video. If you'd like more information, feel free to visit my website or the YouTube channel listed here and my Twitter handle below. Thanks very much.